Hi, everyone. Thanks for joining. This session is called The Behavioral Health Connection to Improving Outcomes and Lowering Total Costs. First, before we begin, I'd love to introduce our speakers today. So I'm joined by Doug Nemesek, who is the Chief Medical Officer for Behavioral Health for the Evernorth organization. Dr. Nemesek is the Chief Medical Executive for Behavioral Health Quality, Integration, and Clinical Operations. He helps ensure network access and availability, patient safety, compliance with clinical guidelines, customer and provider satisfaction, and utilization management. Additionally, works directly with customers and clients to mold operations and provides clinical expertise and new and exciting behavioral health and integrated program development. My name is Robert Capobianco. Everyone calls me Cappy. I am the payer market president for a provider organization called NOCD. We're a specialty behavioral health provider that focuses on delivering virtual face-to-face sessions for people with a condition of OCD. At this time, I'm going to hand it off to Doug to kick off the presentation.
Awesome. Thanks, Cappy, and thank you for the introduction. It's really a pleasure to be able to be here presenting with you today, talking about how we can improve lives and ultimately save medical costs when we're effectively delivering high-quality, evidence-based mental health treatment for obsessive-compulsive disorder. We've long known and seen evidence that when individuals have behavioral health disorders comorbid with chronic medical conditions, that the medical costs to treat them are 2 to 6 times higher. And we've believed that by better treating the behavioral health condition, we can not only improve the outcomes, but lower the total medical spending. But it's been really difficult to demonstrate those savings. So last year at Evernorth, we set out to do a complete analysis of our claims. We looked at over 4 years worth of behavioral, medical, and pharmacy claim information that we had on over 275,000 of our customers. All of these customers had a new diagnosis of a behavioral health condition. And then we compared total medical costs in 2 separate groups. To note, those 4 years of data were from the beginning of 2016 through March of 2020. And so any impact from the COVID pandemic was going to be limited in our analysis here. The two groups that we looked at were those that had outpatient behavioral health visits after a new behavioral health diagnosis. And that diagnosis would have occurred in the year 2017. We then looked at the claims from 12 months prior to that diagnosis, where there weren't any behavioral claims or diagnosis at all. And we compared that to a 2-year claim period post-diagnosis and post-starting treatment. So we tried to control in this for medical diagnoses, the severity of the different behavioral conditions, as well as other demographics like age and gender and things like that. And what we found was for these individuals that received outpatient behavioral health care, we saw total medical savings of up to $1,377 per person in the first year after they started behavioral treatment. That was amazing. And then that was actually sustained over time, where we saw up to $3,109 of savings, total medical spending, medical pharmacy, et cetera, over 2 years post-diagnosis and starting treatment. So really cool findings of these medical savings that we were able to show in total medical cost with behavioral care. And so I want to dig into that a little bit. And you can go to the next slide, Kathy. What we can see on this slide is the medical cost savings per person based on the number of outpatient behavioral health visits that each person had when they first started treatment after that diagnosis. What we saw, and you can see in this graph, is that there's a definite window of adequate treatment that starts to come through, a sweet spot, so to speak, of behavioral health care, potentially, which was that for individuals that had between 3 and 14 outpatient visits, that's where the medical savings really was realized. This is looking at the first years of claims in that first year of data. For For individuals that had only 1 or 2 outpatient visits, we actually didn't see cost savings. And if they had more than 14 visits, we also saw those savings disappear. So this data clearly supports that engagement and adequate treatment is necessary to truly get the benefits of treating the behavioral health conditions. Savings were seen, as I said, from the medical costs and pharmacy put together. Interestingly, it wasn't the pharmacy costs that drove the savings. It really was the medical side that tended to drive the differences, whether that's ER admissions, inpatient admissions, things like that. But the pharmacy costs were included this, both the behavioral health pharmacy and other pharmacy costs as well. And as we look at the next slide, now we're looking across 2 years of diagnosis and claim. And now you can see these savings continue and they actually increase. And when we look at 2 years, and that window, that sweet spot of behavioral health care actually expands a little bit, this time looking between 3 and 19 visits. And we were able to see up to $3,109 in total medical spend. So the savings that we see with adequate behavioral health care are really sustained over 2 years of care. Again, in this chart, we're looking at 2 years worth of data. You can see people with only 1 or 2 visits didn't demonstrate significant cost savings and didn't seem to get adequate care or treatment is our belief of what we're seeing here. As we looked at who was more likely to be in that group that's only getting 1 or 2 visits, the group using that, which made up actually about 28% of the people that we saw who did get behavioral health visits. So almost a third of the people who accessed behavioral health care only used 1 or 2 outpatient visits. But this group was more likely to be male. They were slightly older than those who engaged for a longer time, and they also had lower income than those who engaged for a longer time. And so those are interesting things that we identified with this group as we think about how can we better engage these people to make sure that they're getting the care that they need. Also, as we're talking about the integration in chronic care conditions, in those individuals with 1 or 2 visits, 21% of them did have a comorbid chronic medical condition as well. So certainly the opportunity there for us to do better. And you might ask, well, how do we know if they needed more care or they got what they needed in 1 or 2 visits and actually were better? We actually were able to look in our system and found that more than 10% of them, about 11 to 12% of these customers who had only 1 or 2 visits, actually were back in our online care system doing online searches for behavioral health information, looking for providers, various other things like that. So we know that these individuals, even after those 2 visits, many of them were still looking for behavioral health support and what they could do. So we do believe that it's indicative that at least a significant part of this group likely is facing barriers in finding the care that they need. And we know we want to be able to do more. So we see this as an opportunity to start to promote virtual care options as well, to help engage individuals, make receiving care more simple, more convenient for individuals. And so one of the things we're doing now is making a renewed effort to help guide people to the appropriate behavioral health care that they need, and ultimately trying to help them lead happier, healthier, more productive lives. So bringing those learnings forward now as we look at this slide, sort of into the pandemic and now post-pandemic. Recall I said our claims analysis was pre-pandemic. We're all aware that during the pandemic, mental health needs increased. We've seen an increased demand for behavioral health treatment as well. But in that time through the pandemic, we also saw a significant shift to virtual care starting about March of 2020. Prior to that time, less than 2% of our outpatient visits for our claims that we were receiving said that those services were being provided virtually, even though we've been reimbursing for virtual care since 2017. But in the pandemic, then virtual care quickly shot up to over 60% of the total outpatient care that we were receiving claims for, and it stayed at those high levels all the way through 2021. It was obviously necessary in the pandemic when we were locked down at home, but as patients and providers have gotten comfortable with virtual care, the benefits, the convenience, the privacy, et cetera, have really been recognized by people, and this urge by patients to continue using virtual care when that's appropriate is still there. Studies and surveys have even shown that productivity levels at work are reportedly higher for individuals who are accessing virtual care. So after these last couple of years at Evernorth, we've been actively growing our partnerships with digital and virtual provider groups and those that have the ability to provide high quality evidence-based care virtually for mental health conditions. Digital care expands access, it offers convenience, and it has the capability to build in measurements through the technology and metrics to collect outcomes and demonstrate that people are actually getting healthier with the care. At Evernorth, we've seen some really positive results with these programs, and we're excited that our customers have access to this high quality care. One great example of these partners that we have is NOCD. We've really grown our relationship with them over the last couple of years, initially from just 3 states where we started including them in our network, to now expanding to a national contract over all 50 states. And we're seeing the positive results and outcomes that are being delivered. We know then, based on the study that we just talked about, that as our customers are engaging and receiving adequate care and appropriate care with NOCD, they also have the opportunity to be improving their comorbid medical conditions as well, and ultimately decreasing total medical spend. As I close, I just want to share a testimonial that we received recently from a NOCD customer. This individual wrote into us and said, I've been using the platform for just under a year, and it's totally changed my life. I've struggled with anxiety since college, but it didn't feel like therapy or meds were really solving my issue. I had been misdiagnosed with anxiety for a long time, and exposure response prevention through NOCD was the best route ultimately for treatment for me. The therapist I have is amazing, thorough, and consistent with our sessions. We have a fabulous rapport, and I always feel safe and supported. The surveys and data they run throughout treatment help show how much your symptoms decrease. I believe my last check-in, it had gone down 60%. I was shocked to see how far I had come. I'm truly so grateful we have NOCD, and I hope you never get rid of it. It changed my life. So that's truly the outcome we're searching for here. And with that, I want to turn this back over to Cappy to talk more about NOCD.
Thanks, Doug. That's actually it made my day. That's why we do what we do every day, and why the partnership with Cigna is just so important to us, to be able to reach all of those members and really get them the care that they're seeking. So let me talk a little bit about the solution that we've brought to market. The first part is really where we have community-driven care, right? We started with one of the largest OCD online communities. This is available both via an app and on the web. And what we do in this community, and often in an OCD condition, a lot of our members start to seek out information on the OCD condition online. And so when we're able to meet them and engage the consumer online with like-minded members and experiences, that's the first place that we really develop trust. And since OCD is one of those conditions that isn't widely known, isn't widely understood, the community is very important, both to our health plan partners and to NOCD, to make sure that it's a sort of a gateway and a welcoming place to really find those members, make sure that they understand that there are other people out there experiencing the condition similar to them. And it's, again, a place to build trust and destigmatize the ability to go out and get and seek treatment. That's connected to our nationwide network, as Doug mentioned. Our therapists are specifically trained in the delivery of virtual face-to-face therapeutic sessions with the special therapeutic called ERP, or exposure and response prevention therapy. And it's really the first line treatment for people suffering with the condition of OCD. Since customers or partners like Doug have really been brave to adopt us into network and make us prove our worth and do that, because we were very convinced that we had a solution that would work for this population. We've since grown not only nationwide, but we serve 3 international countries, and our effectiveness of delivering the treatment right around 120 days for populations to start seeing significant clinical symptom severity decreases, which actually lead to the improved outcomes and improvements in life. We don't leave our members, though. Through the technology platform, in between those virtual therapeutic sessions, they're able to access self-help tools, secure messaging directly to their therapist, be able to record their progress in the self-management of the condition in between session. And it also just helps peer advisors and family services that because we take care of child and adolescent cases as well as low down to age 5. So it really gives us that extension into the home and in between sessions. So it's really an end-to-end solution, from engaging the consumer prior to seeking care. So really in that fact-finding and trust-building piece of seeking care, connected directly to the clinical network. And then in between, we use technology to make sure that we don't lose connection with our members in order to make sure that, when they need us and things start to reoccur, that they can quickly get access. And that's how we continue to have durable outcomes as well. So, Evernorth really understood this problem, and many people do not. And specifically, Dr. Nemesek was instrumental in really getting us accepted into Cigna, because he is an expert in this area. So what many people don't understand, and is a significant difficulty with people with OCD, is often we might refer to it as the hand washing disease, or somebody with a type A personality, or somebody that's overly organized. That's just not simply true, right? Those are symptoms of the condition, but it isn't the main symptom. The main symptom is actually intrusive thoughts, where it drives those compulsive style type of behaviors. But people with OCD have about a 10x suicide rate compared to the general population. According to the World Health Organization, it's the 10th leading cause of disability. Often, and it makes OCD very hard to diagnose, is they're about a 90% comorbid with other behavioral health conditions. What happens, though, is that if OCD is not diagnosed and it happens to be the primary condition, you may see treatment going on in maybe addiction or phobias or depression, but you're not necessarily seeing the outcomes that you expect. It's because that underlying OCD is often not diagnosed or misdiagnosed. And this leads to this last piece, which is one of the core reasons that we wanted to make sure that care was more accessible and that it was delivered virtually, is often an OCD patient or member will look and seek for the right care. About 11 to 14 years is typical for the right care journey. All of these are sourced right here on the left-hand piece of the slide if you'd like to read the research behind it. But that sort of led to that, interesting dialogue with our health plan partners about really expanding the access to network around this specialty condition and applying specialty behavioral health treatment with ERP. The kind of tie that back in, the part of limited access was really around the affordability. Again, if you look in lots of different places, often prior to NOCD, you might not find an ERP specialist in network, and when that happens, and you have to go out into the market to get simply diagnosed, could be as high as $500. The subsequent sessions for therapeutic, for the individual therapeutic session could be anywhere between $300 and $350. And that was all when it was non-covered and out of network. And that's a significant barrier to care for most people, to think about that, level of cost going out. In addition, and especially through the pandemic, and it increases into today, the wait list for ERP identified therapists is quite long. It can be 90 days. I've even seen it as high as 120. And often that might make them seek care in more aggressive settings, maybe a PHP. Partial hospital program or an intensive outpatient program. They may even reach levels of acuity that would require a residential treatment center. And obviously that's pretty disruptive, not only to the member, but their caregivers, their family, their jobs, their productivity, as Doug had mentioned. So as we started to partner with Cigna, right, they really understood this problem. And that's why, I think we've had great success with them. As Doug mentioned, I think while providing those solutions, I wanted to talk to you a little bit about just the overall, from a national perspective, on improving access and outcomes. As Doug mentioned, right, and I alluded to that, right around 120 days, and our adequate dose is right within the levels that Doug was mentioning around, anywhere between that 3 and upwards boundary of, 12 and 13 visits. We actually, coincide with that research, and we see that a lot in our patient populations. So we have also kind of taken a step back. This is a peer-reviewed piece of literature that will be accessible at our booth here at the Going Digital Behavioral Health event. So please come by to the booth to come pick it up, and we're happy to give you the URL. It's out there on the public domain. But we took a look at over the last couple of years of our operations, and we, between 20 and 21, we looked at 3,552 adults with OCD who had completed the program with OCD. And when I say completed, I don't mean that we toss our members out, but our mission is to make sure that they have a member first experience and that they learn the tools and the capabilities that they can eventually self-manage, and then come back to us if they need a refresher or a piece like that. But we don't want to see them in therapy forever, but we don't cast them out. So please don't think of completed as we leave them and then they're done. That's not what we mean. But you can see, as we looked at it, very statistically relevant findings again, and this is in a peer-related research medical journal. So overall, the population saw a 43% reduction in OCD symptom severity. And these next points I really want to emphasize to our audience here. We provide OCD care in ERP. Often our members will have comorbid anxiety and depression, of which we monitor. But we treat the OCD. And when we treat the OCD, we see a corresponding reduction in the depression symptom severity of about 44%, and also the anxiety symptom severity of about 48%. I think it's pretty critical because you may have members in a population that are exhibiting treatment-resistant anxiety and depression. About 25% of substance abuse cases also have a co-occurring OCD condition. So I think it's really emphasizes what Dr. Nemesek said earlier around access to the appropriate care actually has a great impact, not only on the condition that you're primarily treating, but has these, secondary outcome improvements around depression and anxiety, as you can see here. It's not always to us just about the condition and improving that for the member, but it's also an improvement in their life. That's really what we're looking for at NOCD. So we also measure a quality improvement scale in life, and it's called the QLES, the short form. And so we see overall about a 23% improvement, in what is really life skills. So as OCD patients become more isolated and the symptom severity goes up, they often lose things like the ability to go to work or the ability to socialize in large groups, the ability to, have, good productivity at work and time management, because the compulsive behaviors start to take and eat into their ability to be productive. So to be able to not only show significant improvement in a very short time with a very efficient level of care delivery, we're really excited about the fact that we're actually returning these people to very high quality levels of life, and they're building back some of those life skills that OCD sometimes can take from the individual as the condition becomes very acute. So we are really proud of our relationship with Cigna and what we've been able to develop across the country. Again, our focus is on member first and making sure that we're reducing suffering from OCD, not only in the United States, but in the globe. So increasing quick access to high quality care for serious mental illness is, directly related to our ability to do this virtually and see people face to face every day. Our focus is improving a patient's life through less disruptive and costly care. Again, when you may not have ERP in-network services, that means, members or patients have to seek these services that can be distance from them, a couple hundred miles to travel, the expenses. And also if they have to go into higher levels or triage into higher levels of care, those can be very disruptive to their daily life, right? Because their extended days into an RTC or a PHP or an IOP really takes them away from their family. It takes them away from their job. It takes them away from the things that they love in their life. We also think that, through this treatment, that we lower the risk of continued suffering by the patient and increasing that symptom severity. As I said, the OCD population has a 10 times higher rate of suicide. So every day that they don't receive care is a day that they begin in that risky type of behavior. And that's really what we want to avoid, because in, a very quick time, we've been able to have, an incredible impact on our members. And we wouldn't be here without the health plan partnerships that we've gotten, like Dr. Nemesek has, been able to support us through. So we're just incredibly humbled by it. And, that's why we wanted to bring the story together, because we do believe that outpatient, virtually delivered behavioral health services is the way of the future for behavioral health. And it wouldn't be without partnerships like Cigna that we were able to prove it. Doug, do you have anything to add there? Or things to miss?
No, thanks, Cappy. This is great. I'll just reiterate. I know as a health plan at Evernorth, you hit on the things that are really important, and that is, how do we get quick access for individuals once they're identified to get them started in care? Two, making sure you have a program that's simple and easy and engaging, so that they do engage in that high quality evidence-based treatment, so we can get that adequate dose and actually get them enough care till they do get better. And then the ability to track and measure and demonstrate that you are improving their symptoms across the board and ultimately their quality of life. Really important, and that's exactly what we look for in partners as well, as we try to make sure we have this available to our customers who are struggling with obsessive compulsive disorder in this case.
Great. Thank you. So with that, I know that Dr. Nemesek and I threw a lot at you in a very short time, so we're more than happy to take questions here in chat. I know that Dr. Nemesek will be around in the event, and people will probably be traveling around. So if you have a chance to chat with him outside of here, please do so. Also, we'll be back at our booth here at NOCD if you'd like to ask questions. But we'd love to open it up and have any texts come in or chats come in.